TV for life. Good evening and welcome to Face to Face for the Newsfirst team. I'm Niresh Eliathambi. My guest tonight is Dr. Samandika Saparamadu, who is a very interesting person in the medical field because he is espousing preventive medicine, and today we are going to talk about non-communicable diseases and how we can all live healthier lifestyles and basically have a happier life. Good evening, Doctor.
Good evening.
Lovely to have you on the show.
Thank you for having me.
Right. So just to introduce you a little bit to our viewers, Dr. Samandika, he qualified as a doctor here in Sri Lanka, and then he went over to Singapore, where he was at the National University of Singapore, and then he went across to the United States, and he is currently a researcher at the very famous Johns Hopkins Bloomberg School of Public Health in Maryland, and he is also an affiliated faculty member at George Mason University in Virginia. So he has quite a lot of qualifications, and I'm not going to name all of them. Very impressive resume indeed. But here in Sri Lanka, he is the founder of the Preventive Research Center in Sri Lanka, and also the founding president of the Sri Lankan Society of Lifestyle Medicine. Right. So, Dr. Samandika, let's start with what is preventive medicine and what do we mean by non-communicable diseases?
Yeah, thanks for the question, Niresh. So let's maybe start with the non-communicable disease part. A lot of people are more familiar with communicable diseases, right? Something that can spread from one person to another, or something that you can acquire from a germ.
Your coughs, your colds, your flu, COVID,
right.
All those things.
That's right. So the difference between communicable and non-communicable, obviously, is non-communicable diseases do not transmit from one person to another in the simplest form. But when we talk about NCDs or non-communicable diseases, maybe I'll continue to use the abbreviation NCDs, much easier.
It is shorter and
yeah.
more practical.
So in NCD, we mainly talk about, in our scope of work, we talk about diabetes, hypertension, heart disease, and cancer, things like that. So mainly cardiovascular diseases and cancer, and to some degree, the chronic respiratory diseases as well. And preventative medicine, I mean, I'm not trained in preventative medicine. My training is in public health as well as in health policy. But yeah, it's part and parcel of the bigger picture of how we go about preventing and helping people to sometimes manage their NCDs better, as well as sometimes even recover from the NCDs. We call it remission of diseases.
Right. Now, the country's health policy, any country's health policy, is a key factor in NCD control, isn't it? But here in Sri Lanka, yes, we have our health sector, wonderful sector where, healthcare is free, and as a result, we do live fairly long lives. But when it comes to health policy, our population doesn't seem to get involved and doesn't seem to be aware of the health policies of the country. How should the government or the health authorities create this awareness with the population as to the targets of the health policies?
Yeah, that's a really good point too. The good way to start this conversation. So maybe I'll give a brief introduction as to what could be a health policy. Is it okay?
Sure.
Yeah. So when you look at some of the laws, regulations, and guidelines designed to help people prevent in diseases as well as protect them from diseases, or rather, in simply put, to improve their health and well-being, both when they are sick and when they're healthy, is can be considered a health policy. So you can see from the definition itself, it incorporates quite a lot of different things, right? So this includes what the government might be doing in the executive branch, all three branches of government, executive to judiciary to legislative branches, and then more planning and implementation agencies, for example, the Ministry of Health and couple of its subsidiaries like the NCD unit, NCD Bureau, the Health Promotion Bureau, etc. They all work a lot with health policies. And then finally, I think the third category, I would say the non-state partners. So everyone, including your organization, the private industries to non-profits and non-profit professional organizations, all of them. So simple things like maybe employee well-being program is a health policy in whatever the context we are talking about it. So I think that will kind of make it clear what we are talking about. And to answer the question, yes, people are aware to some degree, but I agree the dissemination of knowledge is not really optimum, right? There's a lot more we can do. And thank you for having this conversation. I think this also helps quite a lot. And we need to keep getting this message across to everyone. But ultimately, unfortunately, in Sri Lanka, when it comes to health policy creation, the civil society participation is not great, right? It's very limited, in fact. So we have some initiatives to get people from the civil society included in the health policy making process, but that's a work in progress. It's through the Sri Lanka Medical Association. So if anyone is interested joining us today, I welcome everyone to reach out to me or the Sri Lankan Society of Lifestyle Medicine to learn more about that. But having said that, when it comes to actual target audiences of our policies, people are aware of certain things. For example, Health Promotion Bureau does an excellent job with their social media channels and various different outlets, reaching out to people and talking about the risk factors and a lot of preventable diseases. But we, as I said, yeah, there's a lot to be done to create awareness alone before talking about actual change in the society. Yeah.
Right. So when you talk about health policy, now you mentioned some of the NCDs, diabetes, hypertension, and so on. So I presume that the health policies are aimed or targeted at reducing these. So what kind of policies do we have in place?
Right. I think maybe shall I take a step back and give a bit of a context about non-communicable diseases and how we came about this entire story or saga. Because if you go all the way back to 1960s, 70s, so that was the time the Western societies started seeing to some degree, the demographic change, at the same time, the epidemiological transition, which means the disease trends started changing. So at the very beginning of the discussion, we were talking about communicable diseases versus NCD, right? So the communicable diseases, as we all know, this Spanish flu to bubonic flu to fever to various different problems, including diarrhea, had been one of the biggest challenges humankind had faced in the past. But after a while, from 1960s, 70s, people started seeing a lot more people dying as a result of heart disease. So one of the places that had the highest disease burden was Finland, particularly in North Karelia. So they started noticing that they have actually the highest heart disease rates in the world, and they started working on it through mainly, well, a couple of different approaches, but mainly, if I just simplify it, it's a community approach and the healthcare approach. So I think that was the kind of starting point. And then we, in places like Sri Lanka, we started noticing these changes from starting from 1990s to early 2000. So I think that was the time the first directorate for NCDs was introduced, late 1990s, by the Ministry of Health. And the NCD prevention project by the Japan International Cooperation Agency was implemented in early 2000 to late 2000. From what I remember, the first ever policy, actual strategic plan, the national strategic plan for NCD was unveiled in 2009, 2010. I think December 2009. Yeah. So those things have really shaped the way we look at things, and they had a lot of great ideas in them. But the question is to what degree we have been able to implement them and to monitor the progress and evaluate them and to ensure regulation and oversight.
Right. So just to give some practical examples, when you talk about NCDs and the policies, from the public's point of view, what would be the advice for, it's very much linked to lifestyle, of course. You want people to live healthier lifestyles. You need them to stop smoking, stop drinking, and basically behave in a safer manner, a healthier manner, and watch what they eat and have exercise and so on. But that's just general. Everyone knows that. Not many people do that, but everyone knows that. But specifically, for example, if you take diabetes, Sri Lanka has a fairly high rate of diabetes, and perhaps you can link that to the diet. But what specifically would the policy be towards that?
Right. That's actually a great way to frame it. So I'm not going to summarize the things that you already said. This is a good start. So just to mention, since I'm trained in lifestyle medicine as well, in lifestyle medicine we talk about 6 things that we need to take care in order to reduce our risk of acquiring an uncommunicable disease. So I'll stop it there, and let's talk about what policies and what has been done. So if you don't mind just recalling the last part of your question.
Yes. So in practical terms, if you were to take something like diabetes,
that's right.
What would a policy be from a layman's point of view?
I think you might have come across these traffic light signals for sugar content of food.
That's right. Yes.
Yeah. So that is a great initiative.
On the packaging.
Exactly. So that is a great initiative. That's actually a result of a good policy and through the Health Promotion Bureau. So the things like that have been implemented and actually worked fairly well. But at the same time, I think I would rather focus on, because this is something that people already have come across to some degree. Maybe I'll try to highlight something equally and perhaps even more important, which is the salt consumption.
Salt.
Yeah.
Right.
So something very specific, like it's not as bad as saying go eat healthy, right? Because when you say, yeah, you need to eat healthy, people have a lot of questions. So what does it mean? And a lot of people have differing opinions about what constitutes a healthy food or healthy diet.
And
right?
You have your likes and dislikes.
Exactly. Yeah, and then a lot of different evidence from different countries and different regions. Even from Sri Lanka alone, it becomes a more contentious topic rather than leading to some actual outcomes and impacts. You get kind of entrenched into, you get stuck in the conversation.
Now we use a lot of salt in our cooking.
Exactly.
Most of our recipes, traditional recipes, have a lot of salt, but that may not be the best thing. Could you enlighten us as to how bad are we in this salt intake? Because there is a global norm, isn't it? What you actually need. How bad are we?
So general recommended amount, recommended salt consumption for an adult is about, just to keep it around 5 grams or less per day. But in Sri Lanka, this amount on average is 2 to 3 times higher than what is the recommended daily allowance.
2 to 3 times higher.
That's right. And again, it's a much more nuanced discussion. So there's a lot of like, J curves and J curves and different things that we need to consider. But for a public health message and for a population level message, that's a very accurate thing to say. So we have extremely high salt consumption rates, and cutting it down is obviously not an easy thing because people are used to this taste, right? So there was a really good initiative, the National Salt Reduction Strategic Plan, that was I think 2018 to 2020. So that before the pandemic, the government and the WHO, using the shake package, it's a technical package. Based on that, they devised a couple of different directives, some guidelines, as well as actual research to identify what are the high risk food categories, what food items have the highest salt content in Sri Lanka, and how to go about it, how to create awareness, and how to create like a similar traffic light system to give an indication for the buyer so that they can make a more informed decision whether to buy it or not. So that way you can actually drive market changes over time when you keep doing it for a longer period of time. So those things have been actually tested, documented, but unfortunately it did not really take off. So that's something really worth exploring and actually doing right now if we can, because that's some of the lowest hanging fruits. That's something to save one person from having a heart disease or a stroke or other cardiovascular disease, you don't have to treat thousands of patients for something like a salt intervention. Yeah, it's something like smoking cessation. Yeah, it's not as effective as smoking cessation for cardiovascular disease, but it's one of the most effective ways that we can actually bring about most meaningful change in the community, in the target audience, in the target populations with the least amount of resources. Very cost effective.
Right. But again, now this is obviously common sense, and most people do know that you shouldn't have too much salt. But has it really filtered down to practice? Has there been a shift in the population to reduce salt, or is it that once we have a heart attack, then we tend to look at, okay, what should we eat, and right, reduce the salt and so on. Yeah. But are we, I mean, in the preventative sense, is the awareness creation going far enough?
Obviously, the answer is no. There's a lot more you can do. But then again, I mean, you raised a good point about, what can you actually do about it? So even though our discussion is more about health policy, maybe I'll just mention a word or two. So simple things we can do at home. For example, when you're cooking at home, instead of adding salt when you cook, if you can add salt on the table, so that actually reduces your salt consumption by a significant amount, because you don't dissolve salt in the curry, or rather you just cover it with salt, so you get the same sense, the same taste that you want, but you reduce the amount of salt that you eat. And in the same way, there are a couple of other things people can do. I think one of the best interventions would be, it's a little bit more technical, but I'll just limit the technical part to one sentence: increasing your potassium consumption. So simply it means to increase your fruits and vegetable consumption. So eating about 2 to 3 fruits a day, eating 3 to 4 vegetable portions a day, help us to counteract the adverse effects or the negative effects of salt consumption. So those are some of the things you can easily do from home. And in fact, these ideas have been incorporated in the National Salt Reduction Strategy as well. But unfortunately, we are not there yet. Yeah.
Right. And now health policy is a very wide-ranging subject. But can you give some examples where the policy is there on paper, everyone agrees, it looks good, it is the way to go, but then it doesn't work in practice, and that's perhaps a lot to do with awareness creation or culture. What's your opinion on that?
Well, that's a very difficult conversation to have, I would say. So maybe let's start with health in all policies and whole of society approach, because those two principles have been the bedrock of most of the policy documents in Sri Lanka in NCD, because Sri Lanka has been really, actually a lot of policy documents in Sri Lanka are really on point. They have done their work really well. The problem, as you pointed, is where when it comes to planning, implementation, monitoring, and regulation parts. So just to complete the conversation, in health in all policy, we talk about how all different ministries, for example, when you are talking about NCDs, how fisheries, agriculture, irrigation, and then sports ministry, all their policy propositions have something to do with, often they have something to do with health. So the advice is the framework encourage everyone to look at it from a health perspective as well. So that's very important because when you look at from a macro perspective, from a we call it macro system, from an ecological model perspective, when you look at it, when you take a step back and take a look at just one person maybe having hypertension or diabetes, wanting to make a significant change in their lifestyle, they go to their doctor, their healthcare provider. They are told to change your lifestyle, change your walking habits, or maybe do a little bit of more activity. But how they're going to go about that? If you don't create that infrastructure around us in city planning from simple things, then if you don't think about those things in all different avenues, we are not creating that ecosystem. So that's an important part. And the WHO and UN frameworks, they take a step further by getting all the other players also incorporated. So that's the whole of society approach, which means non-profits to private organizations, industries, and civil society, everyone incorporated in the plannings, especially in the entire program. So that's an important part, and that has been done. Again, I'm coming back to the same point. When it comes to planning, implementation, Sri Lanka has struggled not only in health, in many other areas of human development as well. Even though Sri Lanka has excellent human development indices, like, as you know, and also excellent health indicators, from vaccine coverage to maternal child mortality rates, etc. Sri Lanka has had a lot of trouble with the implementation, with sustainability problems, and then regulation and oversight problem. That has been one of the most difficult things, to be honest. So those are the things I think we need to be focusing on. But then again, having said that, we can't wait until the government players or rather the state learns how exactly to do oversight and regulation to start working on something. So it is a kind of a chicken and egg situation. It's a typical in health policy as well. So we have to start from whatever we can start, wherever we can start, like lowest hanging fruits, whatever the most cost-effective methods, where we can get the most benefit per every dollar invested, and then work our way towards ensuring that we have the capacity we need, we have the empowered workforce that we need to make sure that things are regulated properly, and oversight, the government has the capacity for oversight.
Now, Doctor, when it comes to employers, now in some countries such as Japan, employers get very active in the, in making sure that their employees live healthier lifestyles. You see them doing exercises and so on. And in Sri Lanka, this is slowly catching on, but are employers doing enough? And I'd like you to address both the private sector and the state sector here.
Well, good point. Again, well, there are certain things we need to appreciate. So, for example, Sri Lankan, some of the insurance companies, I'm not going to name anyone specifically, but there are some insurance companies who are actually creating incentives for people to be healthier. So when you, for example, like simple things, using wearables, mobile phones, tracking their step counts, and if you consistently, meet certain thresholds, then they are given some rewards. It's similar to your vehicle insurance policies. When you don't meet an accident, then you can get a discount for the renewal. So similar things.
No claim bonus.
There you go. There you go. So the same thing we have seen in some of the online healthcare providers as well. So more you walk, you can keep earning rewards. So these are great things. So now it's a question is how to make these things kind of regular activity, the regular exercise for everyone to be thinking about. Because ultimately, So I think one of the best ways to look at it is a very well established and proven one, which is influenza vaccine. Right? Influenza vaccine has such a good case when even the employer is giving it for free, you still make a lot of money from the employer's perspective. So that's why in many other parts of the world, these vaccines are actually given for free, and the cost is completely borne by the employer. The same goes to a lot of NCDs as well, because I was working with one of the programs at Hopkins. So basically, we were evaluating the program from an economic perspective. So that was Know Your Blood Pressure program. Know Your Blood Pressure. That was the employee well-being program from the employee well-being office at Johns Hopkins. So there, they were just basically trying to get people to have complete control over your blood pressure. It's a patient empowerment program where you give the responsibility of your health back to the people. So that's a great way to look at it, and I think ultimately everyone needs to be thinking about it and thinking how to implement these things in workplaces. But again, if we can actually implement the plans that we have in place, especially the multi-sectoral action plan that was released a few years ago, 2023 to 2027 action plan, that has all these things incorporated, but it's a matter of getting it into practice.
Right, and of course, we in Sri Lanka, we have an excellent healthcare system, and it's a free healthcare system, whereas in other countries such as the United States, where you work, healthcare is not free at all. It's enormously expensive, and you need to have, I mean, each adult needs to have insurance, right? If you don't have insurance, you might not even get employed somewhere, because the employer will say, well, you know, I can't have a liability like this. And university schools, they all require this. But here in Sri Lanka, because healthcare is provided free by the government, it's totally different. Could you sort of look at the two systems and sort of tell us, well, what's better in, you know, our system versus a system where people have to pay for it?
That's a really good question. I mean, so, but again, so let's look at it this way. American healthcare system actually was informed by some of the early research that was done. I can't exactly remember the year. So this famous RAND study, for example. So there, before these studies, I think it's Nixon or Ronald Reagan administration, one of those two. Before that, all the health economists believed that healthcare is price sensitive, or there's price elasticity in healthcare. That means your healthcare utilization rates, your habits will change in response to a change in your price tag. So after RAND study, we learned for sure, for certain, categorically we learned that yes, it is the case. So whenever there is a price tag, whenever there's a copay, people tend to utilize healthcare a little less. So interesting thing is, in Sri Lanka, when you look at our numbers of healthcare utilization rates, it's extremely high, extremely high. So for instance, when you look at primary care services, where this NCD is actually where we need to intervene at the first place, and where we need to make some changes how we deliver care. So it's a very important part. We had, this is data from about, I think, 6, 7, 8 years ago, 54 million primary care visits per year in Sri Lanka. That means that works out to about 2.6 visits per person per year. It's extremely high, highest in South Asia and highest among even among some of the OECD countries. Hospital admission rates, same thing, about 30 admissions per 100 people, and highest in South Asia and some of the highest. 30 admissions
per 100 people.
100 people per year. That's right. So it's an interesting situation. The reason being, unfortunately, we can't just copy and paste the American healthcare system here. The reason being, you know how much people have achieved in Sri Lanka as a result of the free healthcare system, from which was introduced, I think, 1950, 55, somewhere around there. And it has come a long way, and it has built enormous benefits. And in fact, as we discussed briefly earlier, our health indicators are extremely well performing for a long period of time. Even though they have ups and downs, in general, always the best in South Asia, and even has worked as a model for a lot of other developing countries. So unfortunately, we can't just copy and paste, but we can learn some of the things. For example, how to reform and how to regulate some of the private insurance policies by giving a reason to not to seek healthcare for no good reasons, to reduce the healthcare consumption patterns and utilization rates. So those are some of the things we can do. But when it comes to if you're wondering why I'm saying like, oh, don't privatize, because very unlikely it'll help. From the entire budget, we are only allocating about barely 1.5% to healthcare. And when you look at the entire expenditure from a societal perspective, that's about 3.5 to 4%. And how much actually the government is paying is about 40%, and 40% out of pocket, another 20% donor money. So when you take out the donor money, which is going to go away at some point, you're going to be in a 50-50 situation. So just think about it. With all the tax you're paying, is it really worth it? Is it really the situation we want to be in? Because ultimately, it goes to a larger, bigger story. But I think if we have time, we can get there. Otherwise, the message is we need to optimize the way we are spending money. At the same time, when you look at a lot of our budget, the financial statements from the government, we know for a fact a lot of money is actually underutilized. If a ministry gets X amount of money, often 50% to 80% is actually utilized in a given year. So there are a lot more things you can actually do with what we have, and the idea should be to improve the services, improve the quality of care, improve the delivery of care, and use the tax money to bring benefits back to the people through avenues like healthcare, education, transportation, things that have the highest yield, the highest value for money. I mean,
in commercial terms, the highest return on investment.
Absolutely. I mean, look at countries like Japan. How much tax money? So when you look at the Japanese tax from a Japanese taxpayer perspective, for every dollar they invest, they get a little over 50% back in terms of benefits. In Singapore, it's about 40 to 45%. In Sri Lanka, roughly about 35%. So there's a lot more you can do, because ultimately, why do we need to keep paying tax if you're not really getting the benefits that people deserve? And healthcare, education, transportation obviously are some of the highest yield areas where you can actually continue to invest money. And when you have a situation where you are still, after all the taxes, you're paying 50% out of pocket, it's not a great situation to be in. So that's why I would not say privatization is a solution at all at this point in time, for sure, especially without the regulation and oversight part really catching up to what it should be. So we have to slowly work towards something through what we have, and with the revenue we can generate, in order to create a more robust regulation and oversight frameworks. Make sure that everyone is not going to play around when it comes to tax money of people.
Right. Now, when it comes to NCDs, now you mentioned regulation and oversight. Do we need some significant changes in regulation when it comes to promoting healthfulness, towards the NCD situation?
Yeah, I think yes. The reason being, maybe it's a good place to mention our usual contact time between a patient and a doctor or a healthcare professional in Sri Lanka. I'm talking about like many studies conducted in many different settings except for mental health. So when you take out mental health, in all other primary care settings, in urban, suburban, and rural, usually the contact time is about 4 to 5 minutes or less. And in fact, there's a couple of studies that say it's about 1 to 2 minutes or less. So we can't do a lot of things to change someone's behavior in that time span, unfortunately. But there are much more effective ways of delivering care. For example, shared medical appointments and using health promotion approach, community-based health promotion approach in a group setting, where there are about 10 to 15 patients with similar conditions sitting together with a physician and an assistant, maybe a facilitator. It could be a trained nurse, a clinic assistant, or a pharmacist, etc. So that setting enables health behavior change and help us with the problem of adherence and make it more sustainable. And when we combine this with actual community-based health promotion programs, because right now it's all very much fragmented and siloed approaches. There's Health Promotion Foundation that does a great job in tea plantation communities and Plantation Human Development Trust. And Health Promotion Bureau, and a lot of private organizations, a lot of NGOs working on it. And even political parties I've seen recently doing walks on the beach, so which is great. And unfortunately, these are not really connected back to the healthcare system to make it more health-oriented healthcare system. It can be done. So those are the things I think we should be focusing on. And I think I did not answer your question, but so ultimately, when we look at areas for improvement, and especially if I actually answer your question about regulation, we need something to understand what's actually going to happen. I'm talking about a simple example. What's really going to happen between a doctor and a patient? How can we incentivize that? If, for example, if the healthcare provider can be given an incentive, for example, based on the outcomes of the patients, when they are maintaining certain HbA1c level for a long period of time, they get an incentive. Or when they achieve certain milestones, they get an incentive. And that same thing can be done on the patient perspective as well. I'm saying this not just for the sake of saying it, because these things have been experimented in different settings, including settings that are very similar to Sri Lanka. So these are really good ways of investing tax money back into the system. But unfortunately, if we don't have a strong system to maintain regulation and to maintain oversight, we can't launch any of those things, because everyone will find a place to work around the loopholes in the system. So when we talk about incentives, ultimately, yes, the government has to, in other words, to step up and to do what they're actually supposed to do in the first place.
Now, Dr. Samandika, it strikes me that we in Sri Lanka, we focus on a lot of things. We focus on our politics. That's the favorite thing. We focus on the economy. We focus on education, especially if you have children. You're very worried about, which school you can get your kids into, and then the private tuition and all that. We worry about transportation as well. Vehicles are very expensive, and how are you going to get to work? How are your kids going to get to school? So on. But is there sufficient focus on health? And again, from the government point of view, the health budgets have been pretty low, but it's not always about budgets, is it? From the public's point of view, are we focusing enough on health? And I'm not talking about when COVID strikes, everybody is running around. I'm talking about every day. Are we focusing enough?
I think probably it goes back to the Maslow hierarchy of needs.
Right.
Yeah. So when your entire existence is threatened, I think something that may or may not happen to you in 10, 15 years in terms of a heart attack or a stroke might not be your first priority. So we should, unfortunately, we have to understand that as well. So, but the answer is yes, there is lack of prioritization of your health, because it's not like, again, come back to the very first question you asked, it comes back to the point, it's not a communicable disease. So you don't see anything immediately happening to you. You're not going to see getting a chest infection and being hospitalized. It's not going to happen overnight. It builds in you for a long period of time with all the risk factors around you, and give rise to some event at some point that may or may not occur. So obviously very difficult to make people, I mean, one of the best examples would be, I think, undiagnosed hypertension in Sri Lanka. Extremely high rates. And by some definitions, it's up to 1/3 of the population. And when you look at a subset of our population, about 50% of them. So imagine, like, people just walking around with high blood pressure, even not knowing it. But can we do something about it? Absolutely, yes. There are healthy lifestyle centers everywhere in Sri Lanka, and there's a new program coming from the Ministry of Health that will be launched very soon. So creating awareness, I think, is number one. And thank you for doing this today. These things actually help. And creating awareness is number one. But then again, we also need to couple it nicely with the program planning and implementation and monitoring, evaluation part. I'm going to repeat this until, like, to get to a point where where you might be wondering, like, why these guys keep saying the same thing over and over again. I think it's important that we burn it into our minds that these are very important things that Sri Lanka has struggled for a long time when it comes to any type of policy, and especially when it comes to health policy. How to incentivize certain actions from different players, monitoring and evaluation, and regulation and oversight.
Right, and I'm afraid we are almost out of time, but my final question is, if you had the power to make one change in our current health system, the health policies, which obviously would affect the behaviors of the population with regard to NCDs, what would you want to change?
I think that would be the delivery of healthcare in the primary care settings. So that's going to be, in case you're wondering how it relates to policy, so that's going to be a guideline in simple terms. And how we are going to enforce guidelines, or maybe to get them into practice, that's a different story. But I think getting that guideline out and spreading the knowledge and training people, capacity building, and making sure that the healthcare workforce has the competencies to deliver it, I think that would be the top priority. What I mean by delivery of care is how the doctor and the patient, how they are going to spend time when they meet each other for a consultation. Because if the government is going to increase the contact time to 10 minutes, the question is, what are we going to do for 10 minutes? After being trained to treat patients in 2 minutes for so many years, or 1 to 2 minutes, or 1 to 5 minutes, or whatever it is. So we have now 10 minutes. So what are we going to do? We're going to talk about the day-to-day activities or politics or something else? No, so we need to have a clear plan. So you need to know exactly what are the most efficient and effective interventions, and what are the things that will make the patients most likely to make a health behavior change, and what are the things that make patients most likely to continue that habit, or if they lose weight, to maintain that weight range for a longer period of time, minimum of more than 12 months, and obviously in the long run. So I think that would be the first priority.
Right, very comprehensive answer, and my thanks to Dr. Samandika Saparamadu for being with me this evening, and I know that our viewers would have learned quite a lot about NCDs, non-communicable diseases, and health policy. Thank you very much, Doctor.
No, thank you. Thank you for having me, Neeraj.
And thank you to you at home for watching. And don't go away, because the news is coming up next. Have a great evening.